Thank you so much for the introduction, and thank you all for attending. So I am Geoff Young. I'm the Chief of Head and Neck Surgery here at Miami Cancer Institute. I'm also the Vice Chair of the Department of Surgery for the Herbert Wertheim College of Medicine at FIU. I've been here a little over 5 years now, and we have a lot of head and neck cancer patients and a lot of events this month for Head and Neck Cancer Awareness Month. So again, thank you guys for joining in. No relevant financial disclosures. A little bit of background on head and neck cancer for those who might not be aware of it, but it's the 6th most common cancer worldwide, kind of oscillates between 6th and 7th, depending on whatever study that you read. It mainly involves multiple sites in the upper part of the aerodigestive tract. So you have the oral cavity, which is really the mouth and the tongue, the oropharynx, which is really the tonsil tissues and the very far back side of the tongue, or the tongue base, the larynx, which is the voice box where you speak from. We also handle salivary gland cancers, thyroid cancers, skin cancers. So the main risk factors for our cancers are tobacco and alcohol exposure, sun exposure for skin cancer, and then HPV, which does cause some throat cancers. So here's a little bit more of an anatomical diagram. You can see that we're really talking about this whole entire area here. I always tell everybody it's everything above the collarbone, but outside the brain. As head and neck surgeons, we don't go into the brain. That's neurosurgeons, but we come very, very close, as you can see. So and these are the areas kind of that I talked about: the oral cavity, the oropharynx here, nasopharynx sits just above that. It's the back side of the nose. Nasal cavity, the larynx or the voice box, the hypopharynx, which is the very lowest part of your swallowing passages. And that really constitutes the majority of the head and neck anatomy. So, for a self-assessment, self-assessments are important. Most head and neck exams are done by your primary care provider at your routine physical, which, everybody should get once a year. But as we learned in the pandemic, sometimes that can be difficult with, ongoing worldwide events or, just access to healthcare, et cetera. So it's very important that we, examine ourselves and notice when things are changing. Dentists will also examine your oral cavity. A good dentist does this at least once a year. Will examine your tongue and your mouth and, the what we call the mucosal surfaces, or the pink stuff inside your mouth. But they're very limited as to, what they can see in that area. So our first part of our self-assessment is really kind of, thinking about what may be changing in our upper aerodigestive tract. So anytime you have a change in your voice that persists for more than a few weeks, it's probably something you might want to get checked out. And sometimes we don't notice changes in our own voices. It takes somebody around us to say, your voice sounds different, or you sound a little hoarse. Like I said, if that persists for more than a few weeks, it's always a good idea to get that checked out. Anytime we have swallowing problems that we haven't had before, food getting stuck, or pain when we're swallowing, or any issues, we're losing weight because we can't eat or we can't swallow like we used to, that also should be checked out. Any new pain or discomfort in the area of the head and neck is really important. So if you feel a new lump or a bump in the neck, or you're having pain in the back of your throat, or pain in your ears, or pain in the neck, it's always something that we need to get checked out. So one of the first things we do is, we look in the mirror and we can see our skin of our face. Now, it's hard to see the back of our neck in the mirror and things like that, but this area, what we call the mask of the face and the ears, is the most common area that we get skin cancers. And if you think about it, it pretty much makes sense, because this is the area of our body that most gets exposed to the sun. So we want to look at skin lesions. Is there anything that was there that wasn't there before? And, not going into a lot of dermatology, but, we always talk about the ABCDE of melanoma. So any lesion that, is pigmented, that is asymmetrical with different color, irregular borders, kind of wide, evolving, getting bigger, that's something that really should be checked out. Now, it may not be a melanoma, but it may be something that you need to have treated. And the other thing that we're looking for, things like this, lumps or bumps in our neck that weren't there before. Little neck masses in children are almost, usually benign. Neck masses in adults are often cancer until proven otherwise. So we should really take any new lump or bump that persists in our neck for more than a month very seriously. Now, we can get lymph nodes that swell up when we get sick, when we get a sore throat or we get a virus or things like that. But those usually go away. But something that progressively getting bigger, or a mass that was there before that just won't go away, that's something that really needs to be checked out. We look in our mouth. Again, this is usually done by your primary care provider or dentist. And but there are certain things we can do ourselves. So we can look in the mirror, and with good lighting, we can look inside our cheek, look at the surfaces of our gums, along our teeth, our tongue surfaces. This is best done if you look on one side of your tongue, you move your tongue over to the other side of the mouth, and then touch your tongue to the top of your mouth and look underneath of it. So we need to look at all of those areas. Like I said, anything pink, the palate, you can palpate, you can feel for masses in your tongue or underneath your tongue in the floor of the mouth, or in the cheek area or in the palate area. So these are things we can do ourselves with limited instruments and light, mainly using our hands, a good mirror, and a good light. The oropharynx is the back of the throat. So this really includes the soft palate and uvula. And this is what, when we, everybody's experienced, you go to someone, they put the tongue blade or a finger on your tongue and they say, you're opening up your oropharynx. And basically what we're looking for here, and again, this is hard to do yourself, but you can do it. You can also have someone look in the back of your throat. It's looking for anything that's asymmetrical, right? So a normal exam, we should see, good symmetry in the back of the throat. And anything that's there on one side that's not there on the other, any mass or anything bleeding or that's growing out on one side and not the other, it's important to have evaluated. So asymmetry is key. Any mass that's kind of coming out of the pink mucosa, something that you should be concerned about and should have evaluated. So what are some things we may see? So we may see something called an epithys ulcer. This is a benign inflammatory process that usually goes away. These ulcers can be terribly painful. It can hurt. It can hurt when you eat, can hurt when you swallow. It might look something like this, with kind of like a ulcer in the middle and then some inflamed tissue around it. These should go away within a month. And if they don't, if they persist, any ulcer that persists more than a month really should be biopsied. Leukoplakia is a common finding. This is white patches. So leukoplakia is any kind of white patch that's in the mucosa of the oral cavity. So this does not always mean that there's cancer, but leukoplakia can be slow growing. It can progress to cancer. It does not always in all people, but if you do have leukoplakia, it's important to mention it to your dentist, and they may want you to see an oral surgeon or a head and neck surgeon. We also have Dr. Vila here, who is an expert in these lesions. He's our dental medical dentist who follows a lot of these lesions. Some need treatment, some just need observation, but if you see any white patches in your mouth, just make sure that you point them out to at least your dentist and see what they see if they have you want to see somebody. So here's an example of a lip cancer. So this is a cancerous lesion. You can see it looks like an ulcer. It doesn't heal. It's firm. It can be raised, or it can, like I said, be an ulcer. So that's a lip cancer. There's a tongue cancer. So this is a growth that started as an ulcer. You can kind of see the whitish areas around it. This is also another tongue cancer, but you can see this is more, instead of being like an ulcer, it's more of like a mass where you have it kind of growing out of the tongue. We call these exophytic lesions. So that's a tongue tumor. Here are some lesions on the hard palate. You can see this patient has several things. This is leukoplakia. These are the white patches I was talking about. This is erythroplakia, or red patch, and this is a pigmented area. So this actually was a palatal melanoma. So you can get melanoma of the palate. And this patient also, unfortunately, also had a squamous cell carcinoma of the palate at the same time as that. So you can kind of see those two very different looking palate lesions. This is a cancer of the lining of the gums that's eroded down to the bone. You know, it was, you know, started along the gum line here from the teeth and then eventually eroded down. You can see the jawbone is exposed below. Here's what I was talking about, asymmetry in the oropharynx. So you can see the uvula here. You can see the tonsils on both sides. You notice how this tonsil looks way bigger and way more asymmetric than that one. And that's very important. And one of the reasons why it's important is because, you know, you'll often see that associated with neck masses. So again, we already talked about any lumps or bumps that, you know, are here or under the jaw or in this portion of the neck that weren't there before really should be checked out. So what happens if you see something? Well, if it's a skin lesion, you might want to, you know, have a dermatologist evaluate it. If it's in the mass or if it's in the mouth, you know, start with your dentist, but an ENT or oral maxillofacial surgeon, head and neck surgeon are all good go-tos to have something in the mouth evaluated. And if there's a neck mass, you really should go to the ENT head and neck surgeon to get an evaluation of that. So how do we prevent head and neck cancer? So this is Head and Neck Cancer Awareness Month. You know, we really can control this. You know, we can, you know, we know that a lot of these cancers come from tobacco and alcohol exposure. So, you know, stopping using tobacco products is always very good for our health and not only preventing head and neck cancers, but other cancers such as lung cancer. You know, we can reduce excessive alcohol consumption. I'm not saying that you can never have a glass of wine in your life, but, you know, it should be within reason. Vaccination against HPV is probably the most critical thing that we can do to prevent these cancers. HPV vaccines are available starting at 9 years old up to the age of 45. They're FDA approved and they're very safe. And it's very important. It's not only important that we do these exams to try and catch these cancers early, because if we do these exams and we catch these cancers early, we usually catch them in a more treatable state. So if we can prevent the cancer altogether, that's even better. And that's really what HPV vaccination can do. We know that there's been a significant rise in the incidence of oropharyngeal cancers in the United States. And if you look here, you see this is oropharyngeal cancers, and it's going up and exponentially, while other cancers such as laryngeal cancers and other oral cancers and pharyngeal cancers are declining. And this is because more and more people are, you know, realizing that tobacco products and excessive alcohol consumption are unhealthy and can cause cancer, and have stopped those practices. But the reason why pharyngeal cancer is on the rise is because of this, and this is the HPV virus. And it has caused a significant increase in cancers over the past few decades. And if you look at the charts, oropharynx cancer in men surpassed the incidence of cervical cancer in women in 2010, and is predicted in the next few years to surpass the overall incidence of oropharyngeal cancer in men and women. Is suspected to surpass that of cervical cancer. And one of the reasons is these are both HPV related cancers, but cervical cancer has a good screening exam. It has a pap smear. It has a great way to catch these cancers early and then try to prevent them. And we're now starting to see the effects of the HPV vaccination, which was originally targeted as for women, now available to both men and women for obvious reasons that we'll talk about, starting to take effect as well. So the oropharyngeal cancers are increasing, and it's because we don't have a good system, and we haven't had a good success rate of vaccinating, men and women against HPV and until recent efforts have increased that. So we are seeing this, big rise in oropharyngeal cancer, and it is preventable. And getting a shot can potentially prevent some of these cancers. When we get vaccinated against HPV, we're doing it to prevent HPV-associated cancers. We don't have good screening approaches, other than really with pap smears. But other than that, for many of the other cancers, we don't have good screening, and getting vaccinated is the best way to prevent them. And HPV currently causes as many deaths each year as measles caused before there was a measles vaccine. Now we have a measles vaccine. We don't hear about people dying of measles. So we have an HPV vaccine. We hope that we're not going to hear about people dying of HPV-related tumors in the future. So if you look at it, it's in men, the most common cancer we see related to HPV is oropharyngeal. It's almost 3/4 of the cases, 78%. We do see some anal cancers and some penile cancers as well. In women, the majority of cancers are still cervical cancers, but there are oropharyngeal cancers in women. It's right here. It's about 10%. It's a little smaller, but then they have vaginal, vulvar, anal cancers as well. All of these can be prevented with the vaccine. So, if we can prevent cancer by not smoking, wearing sunscreen, eating our vegetables, and that's a lot of work, but, we can also prevent these cancers with just, 3 shots in adults, but for our kids, it's really only 2 shots. And the American Cancer Society now recommends that our children should be vaccinated against HPV at the age of 9. So that's all I've got for a presentation, but I'm happy to entertain some questions. Please feel free to answer in the chat, and we can certainly see what we can answer for you.
Thank you, Dr. Young, for your presentation. Yes, if anybody has any questions, you can submit them in the Q&A section or the chat function in your Zoom. And we do have a question. Should you get the HPV vaccine even after HPV infection?
So that's always a question that comes up. And the answer is, it is FDA recommended until the age of 45. The vaccine does, there are multiple strains of HPV, probably 50, 60, maybe even hundreds of strains of HPV that we don't even know about. There are 9 that we know of that cause cancer and other, problems, warts, things like that. And those are the ones that the vaccine is designed for. So if you've had an HPV exposure, it may not be to one of those cancer-causing strains. So getting the vaccine, might be helpful.